Hi, everybody. Good morning, good evening, good afternoon, wherever you are. I would like to welcome all of you to this new journal club by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University in Saint-Antoine Hospital in Paris, and it is my great pleasure to be joined today by two top faculty, Dr. Raffaella Greco from the San Raffaele Institute in Milan in Italy, and we have also another prestigious panelist also from Italy, Dr. Andrea Bacigalupo from the Gemelli Hospital in Rome. So thank you, both of you, for joining us for this special webinar and journal club. And as you all know, these journal clubs are supported by Takeda Oncology through an unrestricted educational grant. And for the purpose of tonight's journal club, the steering committee of the IACH have selected this very special short correspondence article that was published in the New England Journal of Medicine a couple of weeks ago. And this is very special because, you know, as you probably know, in the journal clubs of the IACH, our focus really is on hematology. And here you may be surprised with the title because we are talking about systemic lupus, but you will see that there is a very close connection to hematology through this CAR T cells story. And actually, just for the sake of introduction, for our audience who may not be familiar with this story, I think we have all learned at medical school. So this is very basic knowledge. Please don't misunderstand me. I absolutely have no expertise in this field, just basic knowledge. Systemic lupus is characterized by the formation of autoantibodies, immune complex mediated inflammation, and organ damage. And we believe that the autoreactive B cells play a key role in the pathogenesis of this disease. Obviously, it is a little bit more complicated because the B cell targeting therapies may not be highly effective. And this is where maybe the idea, the rationale for getting rid of the CD20 negative plasma cells. And what is really fantastic is that in this case report published in the New England Journal of Medicine by Mogiakakos and colleagues from the University of Erlangen and Nuremberg, they have used the autologous CD19 CAR T cells. Remember, these are the CAR T cells we use, and they are approved in non-Hodgkin lymphoma and in acute lymphoblastic leukemia. And actually, very recently, a few days ago, I think 4 or 5 days ago, they were approved in adult acute lymphoblastic leukemia. So you can see the natural history of this story in this young patient, and you can appreciate that this lady has received, but unfortunately the treatment failed. She has received rituximab, tacrolimus, cyclophosphamide, mycophenolate mofetil, MMF, belimumab, hydroxychloroquine. So you heard a lot about it, I think, recently. Steroids, but despite all of these immunosuppressive treatments, unfortunately, the disease was very active. And this is where the investigators thought to perform a leukapheresis to manufacture these CAR T cells in a closed system. So this is not a commercially available CAR T cell. They did a lymphodepletion with the usual classical fludarabine and cyclophosphamide. And after infusion of the CAR T cells, they monitored for some indicators about the efficacy of the treatment. And as you can see on the left-hand side, the B cell count has dropped dramatically, and actually, based on different indicators, this lady has significantly improved, and there was an expansion of the autologous CAR T cells. So this is really amazing, because it suggests that these CD19 CAR T cells may induce rapid remission of a refractory lupus, and this is really shown through the disappearance of the double-stranded DNA auto antibodies. So this is going to open probably, and we'll discuss this with our distinguished faculty, this is going to open maybe a lot of perspectives beyond hematology. So this is my introduction, and then I'd like to welcome again and thank our faculty. And by the way, I'd like to welcome you all and kindly remind you that this is an interactive exercise, this journal club, so please don't hesitate to jump in and send your questions and comments and suggestions, and I'll do my best to share them with the panel. So my first question to you, Andrea, because you are a master in the field of hematology, you've been in the hematology space for several decades, although you always look young, by the way. What is your first reaction to these results, especially that it looks like to me that more and more there is a sort of an overlap between hematology treatments and treatments now we're using for autoimmune diseases, I don't know, rituximab, auto transplant. So your first reaction to this?
So thank you. So thank you, Mohamad, for inviting us. Thank you for the opportunity. The way this story went is that I was getting on my bicycle, because I ride my bicycle to the hospital one evening a couple of weeks ago, and the head of rheumatology, Maria Antonietta D'Agostino, said, a German friend is coming next Monday, and that's the senior author of the letter, Dr. Schett from Erlangen, and he is going to tell us of a case of lupus who is in complete remission 5 months after CAR T19 therapy. And I said, what did you say? CAR T cell therapy in lupus? I was, disbelief was. So my first answer to your question is, do you really mean CAR T cells? And yes, so I met Dr. Schett. He gave a fantastic seminar, by the way. And the most incredible thing is not only the fact that the patient went in remission, and we can talk about that and the sort of what we think about getting in remission with CAR T cells, but she has been in remission without cortisone for the last 5 months, which she had never experienced in her life. So this is the first comment. And of course, I was in disbelief because, first of all, because you never know how much T cells are involved in autoimmunity. And so here you're only targeting B cells, or the B cell lineage, let's say. And not only, but we don't know what the cytokine circuit has to do with autoimmunity. And so this patient simply proves that by really targeting this B cell lineage, you can achieve remission in a patient who is very similar to a low-grade lymphoma, if you think about it, and be in remission for 5 months without maintenance.
Excellent. Thank you very much, Andrea, for giving us the real life story. So Raffaella, you are a hematologist, but also you are the chair of the Autoimmune Diseases Working Party of the EBMT. And I'd like to say hello to all our EBMT friends here. So what was your reaction? And can you maybe, because you've been working a lot in your group and other groups on resetting the immune system in autoimmune diseases. And your approach was about giving high-dose chemotherapy, then infusing autologous hematopoietic cells. So here, why do you believe, can you explain to our audience why targeting B cells specifically, you know, the CD19 positive B cells is through a sort of a living drug? So these CAR T cells are supposed to be persistent, you know, and living drugs. Why this can be potentially effective?
Thanks, Mohamad, for the kind invitation, and hello, everybody. I am really lucky for the experience within the autoimmune disease working party, because it's giving me the opportunity since many years from now to be involved in a really multidisciplinary teams, also discussing a lot with rheumatologists, for example, and also immunologists. And also in my center, we have a really long-lasting experience with immunoresetting, mainly in the field of hematopoietic stem cell transplantation and hematological disorder, but this can be also translated to the autoimmune disease, for example. Just to give you a short overview of what is the current story in lupus patient, for example, we are now in front of a really complex and heterogeneous disease. It generally needs really a multidisciplinary approach, because we have a lot of organ involved, and manifestation can go from really mild disease to a multi-system autoimmune disease that can be really refractory. And we all know that at least more than 50% of patients now are unsatisfactorily treated also with the new biologics, for example. So we are thinking about lupus nephritis, that is really a severe manifestation of lupus patient. And this is really an unmet clinical need up to now, because we cannot be able to give a persistent and complete eradication of autoreactive B cells only through biologics. This is the reason why in the last 2 decades, for example, we have proved and used with promising results also autologous stem cell transplantation in the setting of refractory lupus. And the concept is the resetting of the autoreactive cells. The steps are generally 2. We have one type of resetting. It's a short resetting, and it's generally due to the plasmablast. So they are CD19 positive cells and can be the target, for example, of this CAR T strategy. These are able to give remission in the short term of patients, also lupus patients. In the second type of resetting after autologous stem cell transplantation for autoimmune disease, we have another issue that is really important, and this is the part on tolerance. The part of tolerance, it's really important to obtain a long-term disease control. So I think that we have now to reach and to improve the outcomes of this kind of patient, also trying to target different cells and pathways. We know that in lupus, the pathological mechanism, it's really complex, because we have autoreactive B cells, their connection with T cells and antigen presenting cells, dendritic cells, cytokines, also the JAK-STAT pathway and the BLyS pathway, for example, for the survival and belimumab, that is one of the drugs the patient received. So I think we have a lot of potential targets that can be also innovative strategies for the future.
Excellent. Thank you for really nice explanations. So we have immediately already a question from the audience about, well, and I think both of you can try to answer this. You've been discussing and describing the potential efficacy and feasibility of auto-transplant in these refractory patients with autoimmune diseases. So the question from the audience, why do you believe the investigators, the colleagues who were taking care of this patient actually didn't propose an auto-transplant? What are the guidelines, and why did they prefer to move into these CAR T cells?
Well, I can say from my personal experience, we've auto-transplanted patients with lupus, scleroderma, Crohn's disease. You do get remissions. You as Raffaella was saying, very correctly, Raffaella said, in the short, medium term, you get remission of the disease because you're using high dose cyclophosphamide, and the patients are get in remission due to the fact of this drug, this immunosuppressive drug on T cells. But then, of course, you seem to get relapse, and then the question is maintenance. So I think the authors thought about CAR T19 cells because they knew that auto transplants had a limited activity in this particular non-organ specific, because please remember that lupus is not organ specific. It's not like diabetes. It's a systemic disease.
So maybe, Raffaella, you can also comment on this. And we have a couple of questions about one maybe barrier to auto in such a patient would be the potential high risk of toxicity, because this is a patient who is highly advanced with lots of organ being involved, as Andrea is alluding to the systemic nature of the disease. And we know actually from past experience, and we've done a few of these, that transplant-related mortality when you're doing autoimmune disease is significantly much higher compared to when you do an auto transplant in multiple myeloma. So what can you say about this?
Thanks for this interesting question. Totally agree also with you and Andrea, because I think that autologous stem cell transplantation, it's really effective to determine remission in a large cohort of patients in the short to medium follow-up. And this is why we have also a clinical option recommendation in the BNT guidelines up to now. We don't have up to now a randomized trial in the setting of lupus, so we cannot give the standard of care in this setting. And one major issue, it's also the long-term relapses, because we are able to reach a remission in the short term, but many patients relapse in the long-term follow-up. This is the reason why I pointed out previously that also the tolerance can be a good point to be reached in this kind of patient. What about the possibility to perform autologous stem cell transplantation? In autoimmune diseases, it is really important to have a multidisciplinary approach, as I mentioned it before. So to carefully evaluate all the patients together with the rheumatologist specialist, not only by an hematological point of view. And the timing and the patient selection is really a key issue to perform autologous stem cell transplantation in a safe way. Also to perform CAR T cells, for example, I think this is really important also for the future, to have a careful selection of patients in terms also of inflammation before moving to this kind of treatment, also in terms of toxicity.
But if I can add something, Mohamad, thank you, Raffaella, very clear. But I think this case proves that if you really hit the target cells which are actually producing the autoantibody, you can get rid of the whole circuit, the cytokines, everything which comes after it, including the autoantibody itself. So it sort of proves that the essence, the pathogenesis, lies in the primitive plasmablast, which has undergone, clearly, there's a clone. It's like, as I said, a low-grade lymphoma. It's a clone of plasmablast, which produces these antibodies, which then will cause tissue damage.
Yeah, excellent, Andrea. I mean, it's really fascinating. Amazing. So we have a question here. Well, if these cells, and I think, Andrea, you are very enthusiastic about it, which is great. You've been always innovative and visionary, so, and I always learned a lot from you.
Come on.
So if these cells worked so well in such advanced refractory stage, and hopefully we are now 5 months follow-up, but hopefully this patient will remain in remission forever and be cured. I mean, this is what we wish to her. Why don't we think moving them earlier in the course of the disease?
And perhaps think about rheumatoid arthritis, just to say one disease which is, gets people crippled. And if they can get in a complete, long-lasting, unmaintained remission, it would be incredible. So as you said at the beginning, it's like a bridge between hematology and rheumatology. And I think it's very exciting from a pathogenesis point of view and also from a clinical point of view.
Okay, so you would be willing to?
Oh yes, I'm already selecting. I have a patient with refractory lupus. neuropathy, you name it. She has everything. And now I have to talk with Franco Locatelli, who has a GMP, and see if we can put up a little program.
Okay, so we have here a very important question from Dr. Birgit Schultes. Is actually here in this papers they have targeted CD19, but maybe BCMA would be a better target, the B cell maturation antigen. And actually we have commercially available CAR T cells against BCMA, you know, in multiple myeloma. Raffaella, what would you tell Dr. Schultes?
I think really this is a new era for the application of immunotherapy in rheumatic disease, because as I mentioned before, in lupus, we have a lot of targets that can be achieved through the cellular therapies. So I'm thinking also to the BCMA, but also we can think about the possibility to modulate T regulatory cells, for example, the CAR Tregs that we have in murine models up to now, but I'm thinking also about potential application in the future to obtain more long-lasting disease control. And I think that really this can be the new era for us, not only to have a general management of the autoimmunity pathway of the disease through a drug that can be a driver for not all the targets, but to have more long-lasting therapy that can be durable in the time of the patient follow-up, so the disease can be cured totally.
And that's why CAR T cells may be better than bispecific antibodies.
Yes.
Okay, maybe we'll talk about this in the perspective. So this is a comment from Dr. Fadei about the lymphodepletion regimen that was used. And actually, this is in the papers. This is about fludarabine and cyclophosphamide. And I don't believe we can assume that the response was related to cyclophosphamide, because this patient received cyclophosphamide in the past. So here we have a few questions about the safety, guys, and the toxicities. Because obviously we are all well aware about the risk of CRS, cytokine release syndrome, but also neurotoxicities, which can be quite serious and significant, especially in patients with high tumor burden. This is the experience from non-Hodgkin lymphoma and acute lymphoblastic leukemia. And of course, as a matter of fact, in a malignant disease, you may be willing in a sort of a benefit-risk ratio to accept this kind of severe complications. So how would we counsel these patients, but also how do we discuss with the rheumatologist and the referring physician about the risk of CRS and neurotoxicity? Obviously, this patient, in this case report, everything went marvelously well. But you know, when you start doing 100 patients, you'll probably see some side effects. So how would you envision this story of our safety? Raffaella?
For example, I'm thinking about the possibility to have a sort of modulation, as I mentioned it before, through CAR Tregs, and not only a CAR T against CD19 cells, for example. This can be one option. Another opportunity can be also trying to genetically modify the CAR T cells with a suicide gene mechanism, trying to have also a sort of on-off mechanism of the CAR T in living patients. And this can be really something that we have to see, because we don't know really what is the characteristics of inflammation and CRS and neurotoxicity in this kind of patient, because we haven't any kind of experience.
Andrea?
The comment I would like to make is that we have no idea of what the, let's say, call it the tumor load. So we don't know if that's comparable with a lymphoma. You very correctly said in patients with lots of disease, you get CRS. Perhaps in autoimmunity, the clone is not that big. So if you have, I think if you have a phase 1 trial, let's say we open a phase 1 trial and then we find out in the first 10 patients we do not have CRS, that would mean that the tumor load is small.
Absolutely. And I would add, by the way, because when you look to the experience of CAR T cells in myeloma, actually the incidence and severity of CRS and neurotoxicity is relatively very low compared to lymphoma and ALL. We have and this may be in line with this issue about the size of the.
But of course, the idea of Raffaella of putting a suicide gene is very good. Excellent.
And this is what has been done and published actually in the allogenic CAR T cells that were published last year in the Lancet in December 2020, where there was actually this genetic modification and expression of CD20, but actually, as far as I know, no patient needed actually such intervention to get rid of the cells. We have a comment, maybe a question or a suggestion about this would be about using a preemptive or prevention with tocilizumab, which is the anti-IL-6 receptor. What are your thoughts about this in an earlier fashion? And then you are controlling the complication.
That's standard procedure. I would answer, yes, of course, you need your tocilizumab in the fridge, of course, if you have a phase 1 trial with these patients. Raffaella, do you agree?
Yes, I think we can also make some ideas on biological monitoring of this kind of patient, because generally in lupus patient, differently from hematological patient, we have also the anti-double-stranded DNA autoantibodies. So probably we can also have a look after the infusion of what are the signs, for example, cytokines, and for the CRS, IL-6, for example, or at the same time, what is the clearance of the pathogenetic antibodies in the patient, just to have also a balance between the possibility to have a preemptive administration of tocilizumab or to wait and to monitor the patient carefully.
Okay, so Andrea, maybe I can direct this to you. We have, I would call it a sort of a philosophical question by Dr. Valles there, which is about the persistence of CAR T cells, because these are living drugs. And the common belief, at least in hematologic malignancies, also this is not true all the time, is that you need them to be persistent over time to cure these patients. How would you envision this in an autoimmune disease, where do you think that we need them over on the short term, you know, to get rid of the nasty clone, let's call it like this?
I remember my mentor, Professor Alberto Marmon, used to say that autoimmunity is much more complicated than leukemia, because in autoimmunity you have the target and the effector. So when you say, do you think we need the cells to persist? The answer is yes, because the target is always there. So if you lose the effector, if you lose the control of the effector, which is we think a plasmablast, you will get relapse, as Raffaella was saying, because the target in rheumatoid arthritis, it's your synovia. The synovia is still there, and you will get autoimmunity. So the answer, I think, is yes, we need persistence.
Totally
but time
agree.
will tell, and the trials will tell us.
Yes.
Okay, let's move slightly to our hematologic field, because we have a few questions here, and we always actually compare chronic GVHD after allotransplant to a sort of an autoimmune disease. And by the way, there are many shared features between autoimmune diseases and chronic GVHD, scleroderma, autoantibodies, and so on. So, Raffaella, would you be willing in a refractory chronic GVHD tomorrow to test any CAR T cells? I mean, why not? What are your thoughts? I'm not aware. I mean, I did some search while preparing this journal club. I didn't see patients with chronic GVHD treated with CAR T cells yet.
I really think this is a good question without a reasonable response up to now, but I will try to do some sharing ideas. For example, if we think that in autoimmune disease and GVHD, it's an autoimmunity in a patient after transplant, if we are able to have more knowledge, more in deep about the possible mechanism and the targets that are the major driver of the GVHD in our patient, maybe this can be one possibility, taking into account that also the mortality rate of refractory chronic GVHD patient is really high. But I think we need more knowledge about what are the potential targets, because up to now, for example, in lupus, we have more knowledge about the potential mechanisms that are underlying in this disease. For chronic GVHD, we have a lot of pathways that can be attached by potential cellular therapies.
Andrea, any thoughts on this?
Fascinating proposal, and Mohamad, as you pose the question, I'm sure you are thinking of those luckily few patients who are so desperate that they would want to try anything you have in the fridge if they could get a little bit better in their disease. So the option is there. Raffaella very correctly said we have lots of pathways. But also in lupus, I thought we could have more than, not a simple one antibody. I remember a very nice seminar on how many autoantibodies we have in lupus. You have more than 40 different autoantibodies in lupus, and we don't know what the pathogenesis or the effect of these are on tissues. But then you eliminate the plasmablast, and everything gets in remission. So chronic GVHD is certainly a very interesting option.
So we have an interesting question here from the audience about, again, it's a safety issue that we see in ALL and in lymphoma, and this is the long-term depletion of B cells and the hypogammaglobulinemia. Is this something of concern to you in this setting?
Well, yes, of course. These are already immune deficient patients, and of course depleting them of the B cell component and IgG will, of course, I think bring to chronic supplementary therapy. I don't know, Raffaella, if you agree.
Totally agree, because really these patients are immunosuppressed before starting any kind of treatment, because hematological manifestations are one of the major complications of lupus patients. So they have lymphopenia before starting any kind of treatment. But we have to wait also that any other kind of treatment for lupus will give you additional immunosuppression. So at this moment, I think that we have also to think about the possibility that we don't have up to now a really great therapy in our hand. Probably transplantation, but is not sufficient because we have a long-term relapses. So we have to think really about not only a toxicity, because this patient can have a lot of infection in the follow-up of their biologics, for example, but the possibility to cure the disease, because organ damage, it's really a major concern when a patient with lupus relapse, for example, in the kidney or neurolupus and other kind of manifestation that can be really difficult to treat.
Excellent. Thank you very much. By the way, speaking about immunosuppression, infections, and so on, and because we spoke about B cells, and we know these are the patient with B cell lymphopenia and hypogammaglobulinemia are the most vulnerable to the COVID-19 infection. So I take this opportunity to always encourage everybody to get their vaccine because it can be life-saving, guys. So, of course, we have several questions. Unfortunately, for lack of time, we won't be able to take all of them. There is a nice question by our friend, Dr. Mesbah. He is very loyal to the Journal Club about what would be the inclusion criteria, I would say, and the refractoriness rules. So we'll discuss this once we will design a clinical trials, the famous phase 1 that Andrea is currently thinking of. So again, I apologize for Dr. Al-Fadil and Dr. Haroon. We won't be able to take your questions. It is exciting, but we'll have other opportunities. So now, as concluding remarks, Raffaella and Andrea, where do you see the future there? Because again, I'm not an autoimmune disease expert, but again, I told you I went through and searched the literature, and it looks like there's lots of excitement about not only CAR T cells, but also chimeric autoantibody receptor T cells chimeric antigen receptor in regulatory T lymphocytes and so on. So where do you see the future? Because then, you know, hematologic malignancies are a small niche. If you open this to the autoimmune field, it's going to be a sort of a revolution. It's already a revolution, by the way, but it's going to be really a wider scale of usage of CAR T-cell.
I'm really convinced about the possibility to have a deeper connection more than now about hematology field and also autoimmune disease field, because autoimmunity now can be cured through autologous stem cell transplantation, and in rare indication also allogenic stem cell transplantation with good results. I'm thinking about the possibility to have for the really severe and refractory patient also cellular therapy in the next future. And I think that for now, the new challenge for us in this new era of cellular therapy in this kind of indication can be really the long-term follow-up of this patient, and if the autoimmunity will be cured or can recapitulate, what is the interconnection, for example, not only with the plasmablast, but also with the long-living plasma cells in this kind of patient that are CD19 negative, for example. What is the role of Tregs and tolerance in this kind of patient? So I'm really, really interested to see what is the next future for us in this field.
Yes, I agree, Raffaella. The field of autoimmunity is immense, as Mohamad was saying. In other words, we're talking about millions of people. And we have to be very clear, most of them can be treated rather successfully with the current agents we have. So let's say between 80 and 90% of the patients can lead a relatively normal life. They can go to work, they can have a family, they can have children. So it's most of these patients are being treated currently. But then you have these 5–10% of patients who have horrible diseases, very bad quality of life, and mortality. Scleroderma they get pneumonia, they get the pneumonitis, lupus, they get nephritis. So, and then they have lethal complications. So yes, I think there is a small proportion of these patients in whom, as Raffaella was saying, cellular therapy can be developed and may be extremely successful. And we may learn a lot on how autoimmunity develops. The question is, where did the first mutation occur? Is it a mutation? Is this plasmablast a cell which has gone a somatic mutation or not? Interesting questions.
Well, this is really fantastic. Thank you both. I think you did a great job, and I'm very grateful. I learned a lot from you because you tried to make it very simple and easy in such a complicated domain. I believe it's only the beginning of this big adventure, and hopefully we'll be able, through manipulation of the immune system, to cure more and more patients, whether with malignant diseases or non-malignant or autoimmune diseases. I hope everybody has enjoyed this journal club. And actually, if you are a big fan of CAR T cells, I just realized in my notes that the next journal club in 15 days will be about a recent publication in Blood about the results of CAR T cells in lymphoma versus auto and allo transplant. So obviously, this is going to be a very, very exciting and very challenging. And if you're also following the IACH activities, we're going to stay in the B cell space, I would say, because next week on the 12th of October, we will have a fantastic roundtable discussion dedicated to the post-IMW 2021. This is the International Myeloma Workshop, which was held in Vienna early September. And believe it or not, we'll have 9 prestigious panelists who will discuss and critically comment on the findings that were reported at IMW. We'll have Dr. Baylis, Dr. Costa, Dr. Haruso, Dr. Kumar, Dr. Manier, Dr. Mateos, Dr. Tuzo, and last but not least, Dr. Usmani. So please don't hesitate to join the IACH activity. But for the time being, I'd like to wish you, and This is going to be, I said, October 12th. That's true, the post-RMW. So for the time being, I'd like to thank you all again for your support, and please don't hesitate to send your suggestions for topics to be discussed, for articles. This is an academic open access initiative, and the only goal is to share ideas, to share knowledge and disseminate research to the wider and broader community worldwide. So with this, I'd like to thank you all for your attention, and wherever you are, I wish you a good day, a good evening, a good afternoon, a good night, and please stay safe and keep well. Thank you very much.
Bye. Thank you.
Bye. Thank you.
Thank you. Thank you.